latest advances, and we have a fantastic event today. As in previous editions, this is a hybrid event, so that means we have people in the room, but we also are streaming this event online on YouTube. So the way that this will run is we will be taking questions from both people in the room, but also people who are online. So if you are watching us online, just drop your questions in the comment section under the live stream, and then once we get to the Q&A, we will do our best to answer them. So without further ado, I'd like to welcome and ask Professor Gallagher to speak. Professor Gallagher is the Director of Dementia's Platform UK, which is the project that Great Minds is part of. Thank you very much. John.
Okay, thank you, Ivan. So it really is a great pleasure to speak to you, both near and far today. My role is to make you feel important, because you are. So what I'm going to do is to bring you up to speed with the latest developments in dementia research, some of them anyway, because it's a fast-moving field, and then describe how this is relevant to Great Minds. So let's go on. So let's look at some disease-modifying therapies, the Great Minds Challenge and Great Minds Enhancement, and we may get onto the pipeline. I'm going to look at Alzheimer's disease, as that is the biggest risk, and it also is very complicated. So I'm going to use this as an example so that you understand the challenge that we have in finding treatments for it. Okay, so I won't be long, but focus. So what you have is this protein produced in a cell called APP, amyloid precursor protein. And as it moves through the cell wall, it gets cut up into different pieces which do different things. Now, normally, it gets cut up by an enzyme called alpha secretase, and then the different bits go on and do wonderful things in terms of helping different neurons and synapses work properly. But sometimes it gets cut by beta secretase, and what this leaves is this red bit. And this red bit is called beta amyloid, and the problem with beta amyloid is that it clumps together. And when it clumps together outside of the cells, it, in some way we're not entirely sure, it effectively kills off the cell that it's next to. Okay? So what you have is this protein going through the cell wall, being cut in different places, and part of that then going on to form something called a plaque. Now, what this says is it's very complicated in working out how to develop a treatment, because there are lots of different stages at which you can do something to change the course of the plaque forming. Now, you will all be aware, I suspect, of the recent news about a month ago of a new drug called lecanemab, which has been found to be effective. And I know I was absolutely delighted by this for two reasons. One, it gives us all hope. I say us, I'm part of the team here. It gives us all hope. And secondly, what it does is encourage the pharma companies to dust off all these compounds they've got on the shelves and to try them out, because now we have evidence that they're going to work to some degree. Okay, so that's really fantastic. But just bear in mind that we have this amyloid beta fragment moving along. Now, I'm going to talk very briefly about three drugs. You don't have to worry about what they are, except for the one, lecanemab. So as the amyloid comes out of the cell, it forms what are called monomers, which is little individual protein fragments. Those monomers join together to form oligomers. Those oligomers join together in a structure to form protofibrils. And then the protofibrils join together to form fibrils, and the fibrils clump together to form an amyloid plaque. Is that okay? Is that clear? What you don't want is the amyloid plaque to be formed. Okay, so what lecanemab does if you look at the black line, is it attacks the amyloid beta before it forms the plaques. It attacks it at the protofibril stage. And what this means in general is that the earlier we can attack the plaque formation, the more effective will be the result. Now this is where you come in. So this is the challenge of that Great Minds is engaged with. We're all on this black line here, okay? Right now, I'm probably somewhere down here, and you're probably somewhere up there, but we're all on that line. So what's happening is as we get older, so the changes happen faster. And because they happen faster, they're easier to detect, to measure. So most dementia drugs are tested in this space here because it's easy. You just take people who are already declining fast, put them on, wait for 6 months, make them again, measure them again, and you get your difference. Does it work or not? The trouble with all you folk up here is that you're changing, if at all, very slowly. And this makes it harder to detect the difference. So there are only two ways of sorting this. One is to do very large studies that we can detect very small differences, but they are eye-watering expensive. Right? No one's going to pay money to do those. Okay? Or you do very targeted studies on people who you've identified as being particularly not at risk, as well as particularly at risk. Okay? So you're targeting very special people. That's you. Okay? You are very special people. This is a map of the different people we have in our research register. And we're talking about Great Minds now with 8,000 more or less individuals in it. And what we want to be able to do is to contact you and ask you to take part in a study where we know exactly what your risk status is. Now, we don't want to tell you because you probably don't want to know. I know I don't want to know. You know, if Anne contacts me, I can say, okay, I'll do it, but please don't tell me the results. I'm quite happy as I am, you know, I don't need to know anything else about this. But nevertheless, to have that targeted group. And what that targeted group means is we recruit people according to their genetic makeup and according to their cognitive performance and other things as well. So technically, it's by phenotype according to genotype, okay? All right. So what we've just got permission last week from MRC to do is to ask them for some money so that we can invite you to be genotyped and phenotyped in more detail. Okay? This will make you one of the most valuable Alzheimer's disease resources in the UK, if not in the world. All right? So that's why you really are great minds. You really are. Okay. So I just want to thank you so much for coming. I'd like you to think seriously about when we contact you, supporting our desire to really solve Alzheimer's disease. We're on the cusp, and seriously, without exaggerating, you know, it is. I can say people like you, but it's you. It's you who will enable us to make a substantial difference. Okay, thank you.
Fantastic. Thanks very much, John. Always a pleasure to hear you speak. We're going to move on with the two main talks. We have two fantastic experts from Oxford that we have the pleasure to collaborate with, both academically as well as clinically, and they're going to take a sort of a slightly in a related way, a slightly different look at dementia. First, we're going to hear from Professor Hussain, who's a professor of cognitive neurology at Oxford, who's going to talk to us about the value of screening and potentially the ethical questions that we all have to grapple with when we're screening for dementia. And then we'll also hear from Professor Van Duyn after the coffee break, who talk about what do we actually know about risk factors for dementia. Which hopefully will be tied in with the question of whether we need to be screening for dementia. Okay, first up, Professor Hussain, thank you.
Thank you very much, Ivan, and as John said, thank you for coming and for you being online as well. So I'm going to talk a little bit today about screening for dementia, and I'm going to give it to you from the perspective of a clinician. So at the John Radcliffe, we have our own cognitive disorders clinic. There are 4 consultants who run this clinic, but there are also other memory services run by our colleagues in psychiatry and gerontology as well. So there are many services within Oxford which look after people who are worried about their memory or who have an established diagnosis. So today I'm going to focus on the topic of screening, and I think there are some really important, exciting new developments that have arisen in the last few years. But as Ivan sort of also alluded to, there are some challenges. So these are sort of ballpark figures of what we know. They're a little bit old at the moment, that over 200,000 new cases of dementia are diagnosed every year in the UK. And below that, you see this figure, 480,000 people who have mild cognitive impairment, MCI, and I'll come back to what that means in a minute. But essentially, these are people who don't have dementia, but have come to clinics because they're worried about their memory, and we find some evidence that their cognitive function is not normal, but they're actually managing all right in everyday life, so they don't fulfill the criteria for dementia. So one way to think about the scope of the problem is the iceberg scenario here. And I think the dementia clinical services just see the tip of the iceberg. So right at the top of the iceberg are people who will have an established diagnosis of dementia or of mild cognitive impairment, MCI. And below that, there are also people, probably about a third of the people we see who come to us fresh in the clinic, who don't have dementia or MCI, but they're concerned about their cognitive function. And we call that group of people with subjective cognitive impairment, SCI for a term. So we see all sorts of people, from people who have established dementia to those who are worried but don't actually have any cognitive impairment. And those people also exist below the surface. So what lies underneath from the surface here are also people who have worries about their memory, who don't come and see a doctor. And below them also there are people who have dementia or MCI but are not recognised. They've not been diagnosed for whatever reason it is. And that's a huge part of the population that we're not really getting to. And so those are people with undiagnosed dementia or MCI. And there's also a group of people who are developing the underlying changes that John alluded to, say in Alzheimer's disease, but haven't got to a point where they've got any symptoms at all. And sometimes people call that preclinical disease or prodromal disease. So the question might be, and this is what government might say to us, is why on earth would you screen for dementia or MCI? What are you going to do about it? And I think until very recently, it would have been difficult to answer that in a positive way. But we now know that actually making even simple changes to prevent progression could have an enormous impact. And that could be at the level of lifestyle factors, but also simple things like controlling blood pressure well. Because as we see, these vascular risk factors, including blood pressure, diabetes, smoking, all of those things can also have an impact on the risk of dementia. As John mentioned, there are also some new specific treatments for Alzheimer's disease leading to dementia, And one of those has been licensed already in the US. Another one, lecanemab, as John mentioned, is probably likely to get licensed if we can have a look at the data soon. But there are other reasons why we might want to screen, which is that if you are potentially at risk, you might want to know. Not everybody wants to know, but some people might want to know, and their families might want to know, because you might want to plan for the future and how you use your investments that have accrued over a lifetime. And finally, from the point of view of driving the science and the treatment further, this really might allow us to have a very large group of people with different types of phenotype, as John mentioned, targeted groups that would be suitable for particular types of drugs, but unsuitable for another type of drug. So you might have a very large pool of people to say, you would be suitable for this type of intervention, but not this one. So I think these are important reasons why we could say that it's a good point to think about screening for dementia. And also, even if you manage to prevent the onset of dementia by 5 years, that's great for the person, but it's also great for society in terms of the cost to society of all the care that needs to be put in for that. So I think it's probably worth stating something about the obvious, which is asking what is dementia, because we talk about it. And for a neurologist, dementia is someone who has evidence of significant cognitive decline from a previous level, and that has to be in one or more cognitive domains. And by cognitive domains, we mean things like memory, but also language, executive or frontal lobe type of functions, attention, perceptual motor skills, and also social cognition skills, because some people change in terms of their ability to interact with other individuals. And all of that has to be happening such that it's actually making an impact on everyday life. So the MCI people are those who might have cognitive decline, but it's not actually affecting them in everyday life. And finally, there are some other exclusions that it can't be in the face of delirium. If you have an infection, your cognition might be affected, but you might return back to normal. We wouldn't count you as someone who has dementia. And it's not explained by another disease. So these are just sort of exclusion criteria. So that's what dementia is. And then we have to think about what causes dementia. And as John mentioned, the biggest cause is Alzheimer's disease. But there are other causes. In fact, there are hundreds of causes of dementia if you ask a neurologist. But the big ones are Alzheimer's disease and vascular dementia, which I'll describe in a bit more detail. But many patients also have mixed dementia. They have evidence of both Alzheimer's disease and vascular changes. There are a whole bunch of other things. These rarer causes, the 5%, include hundreds and hundreds of other conditions which are really rare. So what's happening in the brain? You saw that John mentioned these plaques caused by amyloid. This is what they look like under the microscope. They're outside the cell. But we also know that within the cell, there is another type of molecule, tau, which is being deposited. And these two are kind of the hallmark, if you look under the microscope, of what happens in a patient with Alzheimer's disease. And this is the kind of hallmark of someone who might have vascular changes. We call it small vessel disease. The very small blood vessels in the brain, for example, can get furred up in some way, just like blood vessels elsewhere can get furred up in your heart, in your kidneys, in your eyes, if you've got high blood pressure or diabetes or you smoke. So these are the things we can see under the microscope. But when a patient comes to see us, we don't take a sample of their brain to check. We can't do that. It's a too risky a thing to do. So how do we get there? Well, in the brave new world, there are ways in which you can actually scan for amyloid and tau in the brain using positron emission tomography, PET. So here is a normal individual, and you can see the red bits are bits of amyloid. There's very little there. And here is a patient who's been diagnosed with Alzheimer's disease, who has significant cognitive impairment, and there is quite a lot of red here, which is where the tracer is binding to the amyloid in the brain. But there are also people who have a lot of amyloid in the brain, but are actually doing very well in terms of cognitive performance. So that's another issue. These people might have Alzheimer's disease, but they don't have dementia. And that's another important problem for us to confront, is that the positive scan in and of itself doesn't mean you've got dementia. All right? So they have the amyloid being deposited, but actually their brains are resilient in some way to that amyloid being deposited. And the other thing that's really been exciting in the last 6-7 years is the ability to measure amyloid and tau, first of all in the cerebral spinal fluid, the CSF, with a lumbar puncture, but even more recently by doing a blood test. And the evidence at the moment suggests that the blood test is almost as good, if not as good, as doing the lumbar puncture. And you can imagine what you'd like. You'd rather have the blood test than a lumbar puncture. So that's a really exciting development, to be able to measure what's going on in the brain in your blood. And we should say that for people who have the vascular changes, they're a little bit easier for us to spot using conventional MRI scans. Here's a person whose brain is grey here. The cerebral spinal fluid is black, but the white stuff blown up here are the changes which occur with this small vessel disease, those sort of furring of the small vessels in the brain. And that's much easier for us to spot. But the same principles are there. Just because you have these changes, it doesn't mean you have dementia. Some people can have widespread changes but have no problems with their cognition because for some reason they're very resilient. Other people can have a small burden of small vessel disease and be affected quite profoundly. So those are the complexities in terms of trying to come to some sort of decisions about screening, which I'll come on to. So how do we actually make a diagnosis? Well, clinically this involves taking the history, not only from the person who's worried, but also someone who knows them well. And we find that really important to understand what's going on at home. And then we might test their cognitive function. And there are many ways in which we can do this, but this is really a sort of an echo of the slide that John showed you before. This is age along here, and this is, if you like, performance on a cognitive test. And what we've got here are different domains of cognition, from reasoning, spatial orientation, all the way to verbal memory. And unfortunately, the news is not good. Most of us here are well on the way to declining, but this is just normal aging, right? That's how we all go. But interestingly, there's a wide variation. Some people are maintaining themselves at this rate, other people are declining much faster. But on average, this is what happens with age. And if we just make that into a cartoon, this is the normal trajectory. What we're really interested from the clinical point of view is the departure from the norm. When that trajectory declines faster, and it may be that at this level cognitive function is still doing very well, it might be that if the trajectory goes lower still, you might be at a point of having mild cognitive impairment, so you've got cognitive changes but not dementia, and finally you might go over the threshold. You may be at the point where your cognitive function is bad enough that it's actually impacting on your daily life. Okay? So when we're seeing how someone's doing on their cognitive function, we're trying to see how they are compared to the norm. We'll also do a physical examination because there are lots of clues in the physical examination about some types of dementia. Often it's not about Alzheimer's disease, but some of the other types of dementia I mentioned. And we'll do some blood tests and brain scans, like the MRI scan I showed you, or a CT brain scan. But if you were to do this to the population, this is a huge cost in terms of time and resources and people. It's not really feasible to roll this out. If I was to say, I'm going to screen everyone above the age of 65, that would be an hour per patient, an hour per person, plus all the scans that we need to do. So it's not really cost effective. So how can we screen effectively and cost effectively? And the two things that I want to focus on today is doing some of this remotely. So you can be at home, and if you have a computer or a tablet, even a phone, we might be able to assess your cognitive function remotely. And one of the things we've learnt during COVID is that that really is possible, and I'll show you some examples about how that is. The other thing is the blood biomarkers I mentioned. So you don't necessarily need to come and see us. We might even be able to send you a kit at home, and I'll show you some novel ways in which that might work, where you could take the sample yourself, post it to us, and we'll be able to look at your amyloid and tau in your blood. So that's a brave new world emerging. But I think it's important to think about how we counsel people before we did that, because it's all very well having the high tech, but what happens if you come back with a positive result? So I think it's much more important in some ways to explain what that would mean before you signed up to do that. It's very important to know what that might mean. So there are ways in which we can test different domains of cognition, whether it's memory or executive function or planning or your visual constructive skills. This is a platform we've developed in Oxford in our group, and this is one that was developed in Imperial College by my colleague Adam Hampshire. Adam started this whole process 3 or 4 years ago, and he got the BBC involved in the Horizon programme, and they did something called the Great British Intelligence Test. So he actually has over 370,000 people who've participated, who've actually contributed to the normal scales for these tests. And one of the things that we worry about is how robust are they? Well, many people have done this over and over again, and actually it looks like these values are very good in terms of the reproducibility of the test. So he tests different aspects of cognitive function, and I just wanted to show you this study because people during the pandemic were doing these tests, and all he asked them was, have you had COVID or not? If you have, how severe was it? And here are the data from over 80,000 people. So you can get this data at scale robustly, which is so impressive, but also so cost effective. And what he's showing here, the lower the bar is here, the worse your cognitive function is. So if you had symptoms, but not any sort of respiratory symptoms, hardly made much difference. But if you went to hospital and were put on a ventilator and were tested 6 months later, you can see that cognitive function is still very, very impaired compared to the norm by that stage. The important take-home message here is that this is possible. We can actually do this remotely and robustly. And as I said, we've just got to that point where this kind of thing might be possible, that you're sent a little card in an envelope, you have a little stylet, put a little prick of blood on this, you post it back, and the early evidence is that you can get almost as good a measurement from this as having a needle in your arm and having to go to hospital to do it, which is remarkable. So what if a test is positive? I think that's a key issue. And the first thing I wanted to say is a low measurement on one of these tests, the cognitive tests, doesn't equal dementia. There might actually be other causes. So if you haven't been sleeping well, if you're depressed, if you're anxious, all of these things affect the way you perform a cognitive test. So the score on the test isn't a diagnosis. It just tells you that someone isn't functioning well. So it's important. And that's why I think it's really important if you have a positive test that you see a person and you're not doing this all online, because you need to actually be assessed properly in the way we'd see someone who comes to see us. But also it might be very reassuring for you that that person, the clinician, can say to you, look, I don't think you've got dementia, but you have these problems and you need treatment for this. You may also need MRI scanning though, and that might also be reassuring. So importantly, the first parts of screening can be remotely done, but if it's positive, I think you need to go and see somebody to discuss those results, and that's why the counselling needs to come before you even do the study. Also, plasma biomarkers can be positive without someone having Alzheimer's. I showed you the tau and the amyloid PET scans before, that there can be people who have lots of amyloid in their brains but actually are performing really well. Similarly, you could have amyloid in your blood at a high level and be performing really well. So a positive result does not mean you have dementia, and that's also important to realize right from the outset. And conversely, though, both the cognitive function and plasma biomarkers might be normal in someone who does have Alzheimer's pathology in this sort of preclinical stage. So just because it's normal doesn't mean that you can think, I'm going to be okay, right? So understanding these risks and benefits from positive and negative results is very important, and explaining that properly is important at the stage of counselling. Okay, so I think I'm going to come to a close here. I think we are entering an exciting new period. I think this is only years away, and Great Minds is probably only within the next few months that could start, actually. That some sort of screening might be able to be done remotely, cognitive screening and blood biomarker screening could be done in the next few years. And it's the combination of both, I think, that's really important. Having one on its own is not really that exciting. You need to put these two things together. But it's important to understand the limitations of both the positive and a negative result. And the final thing, which I haven't had time to mention today because we've got a 20-minute slot, is this can also have the potential to transform clinical services. We might see a patient every 4 months in our clinic. But if we had information on how they were at home, in terms of their cognitive function at home, when we put them on a particular medication, that would be really helpful by the time we see them again, because we just get these snapshots. And the other thing that it might really transform is the ability for the United Kingdom to perform clinical trials. We have quite a strong infrastructure in many ways that other countries are envious of in the health service. I know we sort of put it down, but we have an infrastructure which is really, really strong. And if we were to leverage that with these processes, we'd be really, really competitive in trying to get new treatments tested earlier than anyone else. Okay, I'm going to stop there. Thank you very much.
Thank you very much, Masood. Fantastic overview. Now, we do have a couple of minutes before we move on to Cornelia's talk for any burning questions while they're still fresh. There will also be the opportunity for a Q&A at the end. But does anyone have any immediate questions for Professor Hussain?
Regarding the cognitive...
If you could just use the microphone so people online can hear.
The cognitive recognition, have you linked up at all with the PROTECT studies being done by Exeter University? Because I believe they have an awful lot of information, because I've been involved in that for a number of years.
You're quite right. In fact, they're using Adam Hampshire's platform. So they use that Cognitron platform. And this is a study that's been looking at people who are at risk of developing dementia or Alzheimer's disease as well. Yeah. So we haven't linked up with them, but they've used that platform and they've had a lot of experience.
I say I did recognise it from
yeah.
Being part of that study.
Right. How was it for you?
I found it very interesting, and I would expect you to be able to perhaps get early diagnosis from looking at those results.
Well, you might, but as I say, you have to just be cautious, because the performance on the result doesn't give you the diagnosis, because there could be all sorts of things. You know,
Yes,
you could be stressed as you're doing it and do badly on that test. So we just have to take it cautiously. Yeah.
Okay, thank you.
Okay. Any other questions? There's a couple here, Simon.
Someone here.
Hi, I think it was the government website that said only about 15% of people with MCI went on to develop dementia. Is that correct?
It's most people would say 9 to 10% per year. So that's the important bit. So if you had 100 people, about 9 to 10 per year would go on to develop dementia. But there are some people who go the other way. So they have MCI and then they can go back into normality because they had mild cognitive impairment, but you treat their depression or anxiety and they're back to normal. So people can go the other way too.
You showed the slide of the percentage of causes of dementia, Alzheimer's, vascular, etc. Does those proportions change? Somebody who develops dementia in their 90s,
yeah, they do.
Does Alzheimer's become more and vascular less, or is it?
Both of those are increasing with age.
Yeah.
But for example, frontotemporal dementia is something we diagnose at a much earlier stage, perhaps in people's 50s or 60s, those numbers were from a population taken some time ago. Other people might say, dementia with Lewy bodies is much bigger than shown here. It's just simply to give you an idea of the.
I just wondered if taking the rarer ones out, the two common ones, whether there was a difference with any.
Yeah, but at a societal level, just if you had something for those two common ones, you'd be making a huge difference. So
we've got a question online as well. Are amyloid plaques the actual cause of the dementia, or is it something else, and amyloid is a bit of a red herring?
Yes, I mean, many of us do wonder about that. I think probably my view is amyloid pulled the trigger at some stage in life, and it led to a cascade of things, including potentially, the development of tau at some stage. But probably the evidence from these genetic studies of people who have mutations in the amyloid precursor protein suggests that amyloid can pull the trigger. It may not be the only trigger that leads to it, but I don't necessarily think the plaques themselves may be the toxic substance. As John was alluding to, it may be also things at an earlier stage before the plaque is formed. So that's a very important question.
And another quick one. How will medication affect the assessments in the study?
Whatever the study is, we would need to know what medications people were on, and of course, to really do the analyses, you need a large enough number of people on that medication to see if it has any impact or not. That's the importance of doing these large-scale studies, which I'm sure Cornelia might get onto as well.
Okay.
Are there any links?
You may just need the microphone for the people. Yeah.
Are there any links that have been identified between diagnosis of perhaps epilepsy or blood diseases of any sort that lead on to MCI or other diagnoses?
Yes, Cornelia here did some of the pioneering work on epilepsy and dementia actually many years ago. So the late onset epilepsy, in other words over the age of 65 say, has an impact in increasing your risks of developing dementia, and the question is why? Is it because you're having seizures and that's somehow damaging the brain, or is it actually whatever caused the late onset epilepsy to start? And the biggest cause is actually small vessel disease, the vascular changes I showed you. So late onset epilepsy doesn't just come out of the blue, it's probably because something happened in the brain to lead to that. And the biggest risk factor is the vascular changes. So, yeah.
Good. Okay.
Do you want one more, or
I think we can hold that question for the Q&A. So we'll have another 20 or 30 minutes with everyone on the panel. Thank you very much,
Thanks.
Professor Hussain. Our next speaker is Cornelia van Deun, who's a professor of epidemiology at the University of Oxford. She's done, as Professor Hussain, a lot of work on the topic. So it'll be great to see where we stand on dementia from epidemiology point of view. Thank you.
Thanks, Ivan. Well, it's great to be here, and I think if one of the messages that I want to give to you is that dementia is preventable to some extent, and we know that, and I'd like to show you the evidence for that. So as we work closely with Masoud and myself, we have the same slide, so don't mind the left side. But the impact of dementia is really big, and I think most of you are here because you are very much aware of this. So there's about 1 million people, perhaps more, with dementia living in the UK or MCI. And that's a major burden, not of course only for the patient, but also very much for the relatives, but also for society, because the cost of dementia is really turning out to be really high on our healthcare system. So the number of patients is only due to increase, and the reason for that is that we simply become older, we have a higher life expectancy, and the older we get, the higher the likelihood is that we develop dementia. Now, as you all know, after COVID-19, of course, is that epidemiologists do in life is counting how many patients there are with a certain disease. And here I am, of course, also into that. And these are figures that we sampled from the Rotterdam study, which is one of the longest follow-up studies that there is in Europe. And what you see here is a little bit a comparison how frequent dementia is compared to stroke. Now, you all are having always messages from the NIH what to watch for stroke, how important that disease it is in the elderly, and of course it is an important disease. But what you have to realize, if you compare the incidence, that's the occurrence of new patients with these diseases, you get a scale which is really different between the two disorders, right? So in early days, strokes around the age of 65 to 80, stroke and dementia are both common. However, if you come to the age of 85, dementia becomes twice as common as stroke. So this is a disease that is really overwhelming us in the old ages. Well, our life expectancy is now around here, depending on your socio-economic class and your health and your stage of aging. You probably are really much likely, as a high educated person, to be rather on the higher side between 85 and 90. So, if anything, I would like to ask you is also make your not only your peers aware of how frequent this disease is, but also use the political pressure, how the urgency is to get this problem solved. Now, if you compare it to Parkinson's disease, you really see the scale is really a scale of more than 20 times difference, right? So this is a disease that is really overwhelming our healthcare. So the point I wanted to make here, and it was already made by Masoud, if you think about the dementia, of course, it's an umbrella disease, and Alzheimer's disease is the most frequent one. As you see here, as you assumed already, who you count depends on the age of onset and where you look at. But we think that the prevalence of Alzheimer's disease as the major cause is at least 60-70% of the patients really show evidence of Alzheimer's disease if you look how the disease progresses. Now, vascular dementia is where you look. Typically, 30 years ago, we said vascular dementia is really an early onset form of dementia. That were the managers with high blood pressure, and they developed problems in the brain, and we labeled that as vascular dementia. But we get more and more the idea that vascular dementia is even more important now at old age, and particularly the small lesions that Masoud showed you. So, Alzheimer's disease, that really is the elephant in the room of an epidemiologist, because that is the major disease that we are encountering. And what we're seeing that if you look at the whole spectrum of ages, the mean age of onset is between 75 and 80. And it's not a surprise, I think there we see the most patients. What we also saw, and that's already known for years, that the heritability is high. It's 40 to 80%, so it's quite a genetic disease. At old age, it's a bit lower, but there is clearly a genetic component that we see in the disease always. And of course, the treatment options are there. I'm very optimistic, even more than John was in his first talk. But I think it's so much, the vibe is there that finally we are close to be able to treat at least part of the symptoms in a way that is meaningful. So the criteria, it's amyloid, and amyloid is in between the neurons. These are these purple plaques that are in between the neurons in the brain, and tau, which is the aggregation of a protein that you see in the neurons itself. And of course there's neurodegeneration, which probably is most likely the cause of the cognitive dysfunction. So this point was also raised. So nowadays we're looking at vascular lesions, not only like blood pressure, but we also look at these small lesions in the brain, but also at the white matter problems. And the white matter in the brain are the vascular parts. The vascular ledger is largely involved there. And what we see is actually, if you look at Alzheimer's disease, if you look early onset patients, Alzheimer's disease only is often seen. But as the age of onset goes on, you hardly see any patients anymore with pure Alzheimer's disease. You always see some vascular problems, particularly if you have a closer look at the MRI. So a lot of people still ask, what are the major drivers? What really makes Alzheimer happen? And the major drivers of the disease from a population-based perspective is if you would follow people over time, and the disease can occur earlier, but in most cases we start counting around 60 and call that already early, but we also have patients with the disease occurring at the age of 30, but these are usually genetic forms of the disease. Now, the major driver is age, and the second major driver is a gene called apolipoprotein E, and that is a gene that we had known already for a long time that to be involved in lipid metabolism. But since the end of the last century, we also know it's a major driver in dementia. And how bad is the situation? Well, if you are carrying the 4-4 genotype, so you're homozygote, as we say, for this variant, then you see, this is the purple curve, that by the age of 90, you either have developed a disease, or most people either died of another disease, lipid problems or kidney problems or other problems that we know are also related to this gene. You can look at this at the risk, which is about 25% that you die of another disease and the others most likely develop the disease. There are old people who live longer, but they're very rare. Now, if you compare that to people who are having only one of these 4 alleles or carrying different allele at the other side, what you see is if you compare the 4-4s to the ones who have only a single copy, they develop the disease 15 to 20% earlier also. And that's the other way that you have to realize. You shift to an earlier time. Now, the difference is even bigger for the people who carry the free genotype, and that difference is coming up close to 20 years in our hands in the Rotterdam study. So, what does this mean? Because a lot of people think, well, if the disease is determined by age, I cannot change my age, I cannot prevent it, right? And if the disease is caused by a gene, what does that mean? Because then I cannot prevent it because it's difficult to edit my genes and change that into another genotype. But that is the reason why we should look a little bit different at these graphs. Because if you look at the 4-4 carriers, which are the high risk group, luckily there's only 1% in the population who are unlucky, then you see the spread in age of onset varies from 60 years to 90 years, right? So that's 30 years. A lot happens in 30 years, right? That's a long time. So what explains that you have such a long period in which you can develop the disease? So there's a lot of thought about that, and one of the things we know is the apolipoprotein E gene is not the only gene. I think we know 80 genes which are determining the risk of Alzheimer's disease, and many are associated in multiple forms of dementia. But we also know that there is an exposome, that all the exposures that you're exposed to over life, which is the lifestyle, but may also be environmental factors like air pollution or medical risk factors, and which may vary from your blood pressure to head trauma. So how can I be certain that we can prevent it? And that is one of the findings that really have been struggling with in epidemiology. And the problem was that what most studies that had a long-term follow-up of persons over 20 years, 25 years saw is that if you compared over age groups, that what you actually saw that there is a reduction. If you look at the same age, people who were studied in 1990 had a higher risk of Alzheimer's disease than if you studied them in 2000. So that happened in the Rotterdam study. We clearly saw that, but it was borderline significant. But it definitely was seen in the Framingham Heart study, which is in Boston. And we even see it in African populations. And it's a little bit more wobbly but also visible in the French population. So what does that mean? So actually people started extrapolating that if you look at these reduction, then the number of patients in a certain year decreased on the age, but due to the increase in life expectancy, the total number has really increased of the number of patients. So that seems a paradox, but it should be definitely there. So if you try to explain that, we really can't explain this by genes, because if you think about your genetic material, that does not change over the lifetime. And even over generations, we don't think your genetic material changes, because if we have children and we think about the next generation, we expect them really to look like us, but we also don't expect that the gene that acts after that really acts after the age of 60 really will matter a lot in gene selection against that genotype. So genes are unlikely, but the exposome, the exposures we have, are very likely. Now, one of the nice papers in 2020, which was a little bit out of the interest, I think, for most people, because everybody was dealing with COVID-19 still, is that there is a commission of the Lancet that really reviews all the literature on a regular basis, and what they try to determine what is the evidence for risk factors that popping up in the literature, whether they are really associated to disease as a cause or as a consequence of dementia. And if findings are not very consistent, as was the case with the French studies showing not that much convincing evidence that the incidence goes down in France, that if you meta-analyze all the studies together, combining them, you get a better power to really find differences that are consistent with all the evidence that is there. So what did they find? Well, I think what is important, that the estimate they come up with, that is that 40% of the disease, dementia, is preventable. What should be realized is that that doesn't mean that you will never get the disease, right? What you try to do is at least prevent, is that you push the disease to a higher age. And one of the advantages of a late onset disease like dementia, if the disease onset is between 85 and 90, you don't have to push that far, because for most of us, our life expectancy is not much higher than 95 around that age, perhaps 100, but very few come older than 100 years. So preventable really means that you push the disease towards older. So one of the most important messages is it's never too early to start, and really early in lifetime. And then we talk about the education level that somebody has is important, but also at midlife, it's very important that we try to prevent the disease. And last but not least, there are these late factors that are very relevant also. Let's have a closer look at that. So education is one of the earliest factors, but if you look at the impact of education, and that is indicated in this last column here, it's quite big. Now, how we should see education as a risk factor of dementia? Well, what you basically would see is that if you are highly educated, on the one hand, you have a lot of cognitive reserve. So basically that means that you can lose a lot of your cognitive functioning without losing your functioning. And that's a bit the point that Masoud makes. Sometimes you really are functioning really well. Well, you lost already a lot. You're already in this downward trend that John and Masoud have shown you. The other way of thinking of education, and it may not only be medication but also playing a musical instrument, is that what it does, it makes more connections in your brain. So instead of connecting two neurons together, you have many more connections between these two neurons through other neurons. And that means that if you lose a connection, you may get there through an alternative way. It may not be as fast as you would like. It may not be as fast as you are young, but you can lose some. So, an important factor. The other important factor, and that's a rather new one they came up with, was hearing loss. And that is one of the factors that I think was a little bit of a surprise, because there's not so many research that targets hearing loss, but the findings that there are, which are a number of studies, 2 to 3, that now show that if you look at hearing loss and you are not using a hearing aid, that is quite a predictor for developing dementia. Now, that has been an important one, because it's not that the evidence is overwhelming. It could be that this is also a consequence of the disease, that the aging causes you to lose your brain function, and therefore your hearing may be all right, but you just can't process it in the brain. But I think it's an interesting one that is really, if it's treatable with a hearing aid, it's really, if that is confirmed, you can see that it will take down your risk quite considerable. Now, these early risk factors, I don't know how you feel about that. Some of you may be quite young, still under the age of 65. But most people under the age of 45 are not very worried about the risk of dementia, right? So are these interventions, are these preventive interventions that people are willing to do at an early age? Well, that's a question, I think, that remains to be answered by just looking how interventions will work. And there's a lot of trials now out there. One of the most important ones are the finger strides that were started up in different settings, in which you just look at the interventions, not one by one, but try to intervene as many outcomes as possible. Now, more likely, you have the interventions that will work at old age. And at old age, there clearly are interventions that really seem to have a big impact. The first one that is important is smoking, which is a really established risk factor. So quitting smoking is definitely something to do in order to prevent the disease. However, there are 2 other risk factors counted here, which are depression and social isolation. And both of them are a little bit of a tricky ones that I would label a little bit questionable, because depression can also be a consequence of the dementia. And what many studies found, that if you look at the risk of depression, it's highest close to the onset of the disease. So that may be a little bit of a tricky risk factor. And air pollution, lots of discussions about that. Of course, if there's more air pollution, you often live in an area that is more deprived, and is that really your social class that we're looking at? Most importantly, if you add them all up, so if you would only start to prevent at late age, you end up with 1 in 6 patients that could be prevented more or less, or in the general population by imposing these interventions. Now, the 40% was optimistic. I think there has been discussions in the literature whether all of these are really as established as we would be. But even if you would reduce it and take all out the ones that are under discussion, you still end up with a number of 1 in 6 patients that you could prevent by just implementing these interventions that aim to prevent the disease. So the action points. Well, it's a very nice paper that it really has been adapted, I think, also into various settings in the NHS, that you start thinking on how to prevent the disease. And that's clearly a lot of the preventive interventions is not only targeted to Alzheimer's disease, but really to also prevent cardiovascular disease. It's preventing head injury. I think even if it's questionable, I think everybody should agree that we should try to prevent that. And stopping smoking, I think for all reasons, it's not only the dementia, but also for cancer and cardiovascular disease, it's an important intervention that you would like to do. So the pollution, it's questionable, but we should, right? There's a lot of reasons why we should. It's not good for our lungs, and if it's doubtful for the dementia, we should definitely do the intervention independent of we think that is true. And obesity is clearly also a cardiovascular risk factor. So the other risk factors also very much overlapping with cardiovascular disease, exercise, not too much alcohol, and reduction of depression. I think everyone couldn't agree more that we should try to prevent that and treat that in the earliest phase. So the hearing impact, we are very much interested in that, in researching that further. That would be a very important question, because if you just think about your peers, there's often people that after the age of 60, there are problems with hearing and people don't wear a hearing aid, and that may be not the best idea. One of the reasonings why this could be true is that if you don't stimulate parts of the brain because you don't hear, that part of the brain will degenerate and that will affect somehow your cognitive reserve. But it's not clear as written in stone, but on the other hand, I think it's one in many reasons to take a hearing aid in the case of hearing impairment. Now, last but not least, the social context. That could be a consequence of the disease, but it could be also something that in general that we know is very much associated with increased mortality, something to act upon, as well as everybody should have the right to have education levels. Now, shortly I would like to dwell upon the question, is this it? And I don't think it is. I think what we see, and also Masoud alluded to that, as well as John, is that there are blood-based biomarkers that will really fuel research, and definitely it will take epidemiology further. How? Well, all the questions we had, do hearing aids help? If we can test a trial and sort out, give people, some people hearing aids, some people not, and see whether there are blood-based biomarkers that show that you improve, that would be very important for people. That would be helping us a lot. And as Masoud has shown already to you, that may be very simple measurements which can be done with a blood prick. We can just send the cards around and do the trials. Now, what is also clear, and that is more the work that we learned from genetics, that if we look at all the different cells that are involved now in the disease, we used to think that Alzheimer's disease was a problem of the neuron. That is dying and probably related to the cognitive dysfunction. But we also see a lot more problems now in the disease, and that is looking at different cell types. We first figured that the astrocyte is associated with ApoE function, but now we're starting also thinking that the activated microglia are very important, and that points to immune diseases. So what else is there to do? Well, a lot of people always ask me, can't you do something with diet? Because it must be that a healthy diet should also help you. I think it's not reviewed by the Lancet Committee yet, but if you look at the studies that did large-scale proteomic and metabolomic studies in the blood, and that is usually looking at proteins, which are coded by the genes, as well as metabolites, which are active components like glucose or your cholesterol levels. What you see that the findings are extremely consistent, that branched chain amino acids, so these are a kind of amino acids that are found to be reduced in patients with Alzheimer's disease extremely consistently. And that may point that there is something either in the metabolism or the diet in the patient that lead to this, and that we don't understand yet. But as we know we can modify this by diet or medication, we can act upon it. There's also the fatty acids. So we do see very consistently that you see the fatty acids that are associated with fish and which are unsaturated are reduced in the patient. And again, you can act upon that. You can really intervene on that and improve that. Now then again, the last point that also Masoud made, that really there is a lot of development in interventions with medications. And these interventions, they may be important to support this prevention. And I think that what is important to realize that if we look at a similar disease where we had an enormous success in prevention, that is cardiovascular disease, right? And what we do in cardiovascular disease, if you go to your GP, he or she will measure your lipids, your blood pressure, your glucose, and look at all the aspects of the disease, whether the hemostasis is okay, whether the clotting of the blood is okay. There will be a general look. Now, of course, you get the advice then stop smoking, but you also get, if your lipids are high, you get a statin to get, or an anti-lipid medication to get the lipid down. And I think that will be the end point of this disease. I think it will not only be lifestyle interventions, it will also be a combination which we will need with drug-based, medication-based interventions. Now, there's a lot of discussion on lecanemab because really it was one of the findings that which you can see that you can delay the disease. Now, it's estimated on Monday there was a presentation on it in American Association, and they said 6 months at least, right? The question is when. I think when do you want to extend it, right? I think most of us, if you think about Alzheimer's disease, which usually start with a period of confusion, difficult of thinking, but then a period of acceptance of the disease, and then a deterioration also leading to the patients being bedridden. So I think most of us would say not here, right? But would you like to start in it already if you have mild cognitive impairment? Or do you want to be earlier? Now, I think that's a discussion we have to follow, because that is bringing up the question also Masoud raised, who's willing to intervene earlier? Because if you are wanting to do that, you also pay the price that you have to pay something on the knowledge of the disease, right? We don't have to communicate that directly. I think that is the point that John made. but there is some price we pay in this setting that you will have to do some testing and some screening. So the take home. I think the take home is really the dementia epidemic is curving, so it's preventable. We know a lot about it, more than ever, but we also will be finding out a lot more now in the coming 5 years using the blood-based biomarkers and see whether people really show evidence to improve. What we also now know, there's no single bullet to cure the disease. As the case for other common diseases, we probably need a lot of combinations, and to make that happen, again, we need all these efforts of people willing to try out the different approaches. And that's it. Thank you for your attention.
Fantastic. Thank you. Thank you very much, Professor Van Duyn. We're right at the time point for the tea break, but I'm going to allow two burning questions. Bearing in mind we'll have a Q&A after the tea break, so we'll have the opportunity to really drill into anything that sort of we may want to explore further. Does anyone have any immediate questions for Cornelia?
I'll jump in with one online. Why does mental stimulation not appear in Cornelia's action path to increase cognitive resilience?
It is a good point. So the most compelling evidence is found for education, so an early setting, and that is the time that you're building up your cognitive reserve. A lot of people have looked into the problem. If you keep stimulating people with at older age, does that have an effect? That is not completely proven and therefore not accepted yet by the Lancet Committee. So it's clear, it's beyond doubt that this education part in the start seems to push the onset of disease later. But whether in later phases it also will help is not clear yet.
Okay. Go on.
Another one online. There's not one in the room. Hearing impairment often leads to depression and social isolation, and the issues are not always easily solved by hearing aids. Has this been considered in the prevention stats?
Yeah, definitely people are thinking of it. Is this a consequence of the disease, but also is this a consequence of a broader spectrum of the disease? And the number of studies that have been focusing on hearing aids has just been very small, and they don't find evidence towards that direction, and therefore it has been accepted by the Lancet Committee as a possible plausible cause. But the evidence still, there are very few studies in the world that really sampled data on hearing aids, and they just don't exist. So the problem is we will need to get more data.
Good, fantastic. With that, I'd like to invite you, those of you that are in the room, to join us for a quick round of refreshments. We'll be back here and online at 4 o'clock, so in 25 minutes. Say again? Yeah, so at that point, we will have about half an hour for a Q&A. We'll be able to get to all of those questions that are still remaining online. Good, okay, fine. So we'll see you back here at 4. Are we ready to go live? Hi again. So we're fashionably late for 1 minute past 4, and we're ready with the second part of this afternoon. I'm going to, if you like, try and recap what we heard from Cornelia and Masood into how does this feed into what presumably a part of, which is the Great Minds Study Register. Where does volunteering for brain health research fit into this scheme? So this is a sort of a very famous graph in dementia research, which is sometimes criticized, but I think it sort of brings home an important point, and that is that we now know that dementia, and specifically Alzheimer's disease, starts up to 25 years before people have any symptoms at all. How do we know this? We know this from studies done in the United States, where they pick up on a relatively rare cause of dementia, which is specific genetic mutation, which means that people develop Alzheimer's at the ages between 50 and 60. And what they're able to do is they then essentially contact essentially the children of these people, and they found the ones that have the genetic mutation, which means that they will definitely have the disease at the age of 55, say. And they start from say, their 20s, they start to look at these biomarkers that Cornelia and Masood were talking about. And they start sort of bringing them back every year and seeing essentially asking the question, what is the earliest time point that people start to see a change? And that is the resulting graph. So you can see lots of different lines. The truncated line is the time point where the person actually comes to you and says, well, I don't remember things that happened recently. I'm okay with remembering my high school girlfriend, but I really struggle to tell you what I've done yesterday. So that's the time point when we're actually talking about the first symptoms of dementia. And what these people found was that the first time point where you see a change is about 20 years before first symptoms. That's the yellow and the orange line. You start to see the accumulation of these amyloid plaques in the brain. That's the orange line. It happens about at that stage. Then about 10 to 15 years before first symptoms, you start to see a change in the green line, which is the tau protein that Masood spoke about. That's the one that is really toxic to the proteins. So that happens about 10 years before first symptoms, and about 5 years before you get any symptoms is when, if you bring somebody into an MRI scanner or one of these glucose scanners, you start to see that the tissue of the brain is starting to shrink. So that is the dark blue line, the hippocampal volume. So what that means is that we're dealing with a disorder in the case of Alzheimer's disease, which is decades in the making. Okay, to some people that's incredibly scary, and yet it also tells us that there's a window of opportunity. Okay, there's a real possibility to actually, if we know a lot about people as they age, we're able to actually pick out the ones who are most likely to be in this stage where, if we have the tools, there's something we can do to stop the process before there's any damage. And you end up with something like this. So this is what's called an area under the curve type of graph, where you are trying to identify what is the likelihood that somebody will have this preclinical form of Alzheimer's disease if you know a lot about them. So we take the factors that Cornelia was talking about, like their age. We know that relates to dementia risk. We take their sex, we take their genetics. This is a study that we run on one of the cohorts that we have access to, and if you put these factors together into an algorithm, you start to see, that's the purple line, that you're able to capture about 80% of people just by knowing these factors about them. And then if you add a bit more, if you add a bit of knowledge about, for example, their cardiovascular risk, do they have diabetes, do they have hypertension, what is their body mass index, if you add these things to the model, this is the red line, you start to see that, at least in this case, we're able to identify these people with 90% certainty. And what that means is that if you have all of this information on people, you can do what we're trying to do with Great Minds. So essentially, people who have been part of research cohorts, as part of which they've done all sorts of testing, they've had their genetics done, the researchers have recorded whether they have diabetes, whether they have hypertension. So we have all of this rich data, and we're asking the question, can we then essentially, if you like, create a platform where we are contacting these people on the basis of what we think their risk is, that they may be in this highly informative stage of being 5, 10, 15 years before first symptoms, and to offer them to do research and accelerate finding new treatments for the condition. So that's where we are. That we've made this proposal to a number of existing cohorts in the UK, and we've got to, I think, a very respectable number. So 8,000 of you have actually gone online and said, yes, I'm happy for my data to be used for this. And not only this, but I'm happy to be contacted on the basis of what your smart algorithm tells you about my risk, which is a fantastic thing, and my respect to all of you that are in the room and online. So as part of this, we're also giving some cognitive tests that are done online, and already we've had, so this has been going on for just over 2.5 years, and we're at 8,000 people, and we've had more than 10 studies that we're supporting through Great Minds. This is what it looks like. So this is what a researcher sees. These are all the people that have agreed to be part of this research register, and we're asking specific questions about whether you'd want to be involved in clinical trials, or whether you're happy to have an MRI scan, whether you're happy to have a lumbar puncture, so that we'll only contact you for the sort of things that you've already told us that you'd be interested in, and we don't contact you for the sort of things that perhaps you've had a poor experience in, and you'd prefer not to be contacted. And we are doing a couple of other things which are sort of very closely related to what Masood was saying. So we're just about to start a study where we are bringing people in to the John Radcliffe Hospital to do blood testing, and if you like, really enrich the sort of data that we have on our volunteers by also having this last piece of the puzzle, which is the biomarkers that are relevant to Alzheimer's disease risk in blood. And so I think when this is all completed, as John was saying, we will have, if you like, the richest and most informative group of brain health research volunteers that certainly UK has, if not worldwide, to really place the UK as the place to do these sort of research, to revolutionise dementia treatment. So if you are not part of Great Minds and you would like to be part of Great Minds, the way to do it, and there's some leaflets that can show you this at the end if you want to pick one up. Essentially, you go on to the Join Dementia Research website, which is the official, if you like, NHS Dementia Volunteer Register, and from then on there is a link specifically to Great Minds, because we are able to go the extra mile in comparison with Joint Dementia Research, in that we can send out genetic kits out to people. We ask them to do the cognitive tests online, and if you like, create this much richer database for researchers to be able to select people on the basis of. So that's what I wanted to talk to you about. And the next part in today's event would be the opportunity for everyone to really ask, not so much me, but certainly the experts that we have here, Cornelia, John, and Masood, to really take a deep dive over the next half an hour into any other question you may have about dementia risk factors, dementia prevention, and see where we get. Good. Okay, let's go.
Can you hear me? I have two questions. Inflammation has been mentioned, and genetics. Can you tell us anything about the role or not of autoimmune disease in this, and related but slightly different, gut health is something I think that has been mentioned as well recently, and I'd like to know a bit more about that. And a general question that I always have is, are there any serious studies about what certain foods do, the effect that they have on conditions, the way they react on blood markers, and because I have in a different area, my long-term condition, I have a strong suspicion that what I eat sometimes interferes with my blood results. So, I mean, that's a big collection, I'm sorry, but...
I'd say these are three questions. So, autoimmune, sort of inflammation / autoimmune disorders, then there's the gut question, and then there's the diet question. Good. Autoimmune disorders and neuroinflammation?
Well, I think if you think about autoimmune diseases, usually people have a genetic susceptibility in the HLA locus or MHC locus, and that piece of DNA pops up also as relevant for Alzheimer's disease. So from that we always think there is a problem, and it doesn't have to be autoimmune, because in that region there's also non-autoimmune diseases, but it's definitely, I know, a point of interest in industry, because I think there's more and more evidence that complex is also presenting protein structures that are fault, so they're misfolded, they should be destructed, and these HLA compartments just are also helping to clear these faulty proteins. So that's one of the reasons why people are interested in that. But in general, I think you don't see that many more autoimmune diseases in patients with Alzheimer's disease. We've been studying that now for 30 years, but there's not strong evidence. But you may know more about
clinically, Masood?
Yeah, clinically there are some rare autoimmune diseases like lupus, which can affect the brain in only a fraction of the patients, and we know that. And treating those patients can make a difference to their cognitive function. If you extend what you call immune multiple sclerosis, you might think of as an immune-mediated disease, and that not only affects people's limb function or their bladder function, but it also affects cognitive function. So there is a role for thinking inflammation in the brain can affect brain function. That's for sure. Whether it is a causative link to something like Alzheimer's disease, I think the evidence there is much less sparse, as Cornelia suggests. In fact, inflammation has been implicated in other diseases as well, Parkinson's disease, all sorts of neurodegenerative diseases. And then the question becomes, is it just a sort of consequence of the toxic effects of these proteins being laid down in the brain, that understandably the body is reacting to these toxic species, and therefore you're getting inflammation? So that's a very general response to your question, but I think that probably gives you the overview of where we are with the evidence. The gut microbiome is something that's become very, very popular across many different conditions about how that affects brain function. Personally, I think the evidence for that is not very strong at the moment, but that doesn't mean to say it's not going to be important. But I don't think the evidence for that is very strong.
Any thoughts about the gut? I know, Cornelia, you were trying to convince me a little while ago to be collecting
I'm intrigued
relevant samples from people.
The reason why I'm intrigued with it is that you can make animals, you can build in human genes in there, and as you may have suspected, I'm very much working on genetics, and if you build in the APP gene in an animal, you see that animal changes its gut microbiome, and that is so intriguing that you think, why does it do that? But I agree with Masood, we usually agree, so dementia isn't the strongest evidence. For Alzheimer, dementia definitely not. Where the evidence is pretty strong is more for Parkinson's disease. That's a disease where you see often obstipation, reduced gut mobility. And you see there quite some evidence that the findings are consistent, that you see certain microbiota overgrowing in that gut of patients. The other one is epilepsy. That it's really one of the treatments for epilepsy is targeting the gut now, so it does something on the brain. And depression is really strongly associated. There's some clear evidence that your gut microbiome changes, but then I think a clinician will tell you if you are depressed, you change your eating habits. So what will happen? Your gut microbiome will be different, right? So you often in the diagnosis of depression, you gain weight or lose weight.
Good. And to come to the end of this question, which was worth 3 PhD programs, there was the question of diet. So I don't know, John, do you have a view on diet and dementia?
Well, my problem is I'm heavily biased towards English breakfasts. So that's I think if there was the most likely pathway towards it, it would be through vascular health. I haven't seen the evidence that diets can have a large effect on inflammation, apart from where there are people who have particular issues. So, for example, I am lactose intolerant, so that would really affect me if that particular dietary factor. But at a population level, speaking generally, my view is that it's largely a vascular effect.
Okay. We've got a lot of questions online. I'll just go for one of them. Are there international comparisons of the percentage of the population with dementia that could suggest any environmental or lifestyle factors that contribute towards rates of dementia?
Ooh, there's a lot of data in the start already. I think we had the Isle of Guam, right? Where you had very typical pattern of a dementia, a cluster of ALS, Parkinson and dementia. What we also see that in a lot of Asian countries, there's much more a push towards vascular dementia than Alzheimer's disease. So there really are differences across the globe that we see. I must say that that was more a hot topic, I think, 30 years ago than now, because I think with the globalization we start being more alike. But I think there is quite some evidence that there have been differences.
Yeah, it's also the education about vascular risk factors is a really important issue in terms of general practitioners thinking that your blood pressure really needs to be below 140/80. That's what I would consider to be the kind of limits you should be thinking of. Every millimeter of blood pressure above 140 systolic changes your cognitive function. And not even, GPs in the UK really understand that. So that's why people who come to our clinic, we're really tight on the blood pressure control. And part of the reason in South Asia that undoubtedly it's genetic, but also high blood pressure. Blood pressure needs to be really controlled. So there are differences, but it may also be simply because of how healthcare works.
And I don't know whether you see this as a neurologist, but if you look at the elderly women after age 85, there's still a lot of women who have higher blood pressures. They're huge numbers. I think they're more in psychiatry with Ivan than with Masoud, but they're very many.
Do you know what
women.
a blood pressure cuff is?
I've seen a picture. Very impressive piece of kit. Good. More questions online, Simon, or anyone in the room?
I'll carry on here then. Do groups for the prevention stroke slowing of cognitive impairment exist, such as cognitive stimulation therapy, and are they tested and offered in... Oh, sorry, it's probably a separate question from the same person. Cognitive stimulation therapy offered and tested in the UK.
Yeah.
Do you want to go first? Because it's your...
Sure. I mean, I'm not aware of any of those kind of studies that have been done. I think the closest ones are the finger studies you mentioned in Finland, which is lifestyle intervention, which looked after many factors, including physical exercise, diet, these kinds of things. So there are very few direct studies. Even the studies about blood pressure are sort of slightly indirect. They're not direct trials which were looking for cognitive function or dementia as an outcome. So I think the finger studies probably are the...
Yeah, but I thought the question is also about activation of cognitive, so stimulation.
Yeah, I'm not aware of any of that.
I think there are studies, but most of these studies, by definition, have been relatively small and short follow-up, and that makes it very difficult to reach a conclusion. So we discussed that before. I think if we have better measurement, it would also be quite interesting whether it works. But we think more that the cognitive stimulation early in life, whether it's education, but some people are also convinced that if you play an instrument which is a very high cognitive function, you also helped with your brain reserve. So I think that is more towards what people think. It's the early life exposure.
One thing we didn't talk about is these remote cognitive tests have the potential to be more sensitive than the traditional tests. And if that's the case, those outcome measures might be more amenable to 6 months of intervention. 6 months is not a very long time in a lifetime, so you want a very sensitive measure to be able to show there is a significant difference.
John, you wanted to jump in?
Yeah. So if we put cognitive enhancers to one side, so we're just talking about use of the brain, and if we put early education to one side, then there are studies which show that, which are designed to test the use it or lose it hypothesis, and there are data which show there is a benefit. But the question for me is, what is the benefit? So, for example, does doing a numerical calculation task affect my ability to solve a problem, a verbal problem? And the evidence is that the cross value is limited. So then that makes me ask the question: well, if there are these benefits, and for example, doing jigsaw puzzles, which I can't do, the Times crossword, which scares me, completely silly. But if there are these benefits, are they due to slowing down the neurodegeneration, or are they due to improving the efficiency of the your current neural network? So, for example, are we affecting my ability to do something more efficiently, or am I, which is a software issue, to use a computing parallel, or am I affecting the hardware? And I don't think anyone knows. Now, until recently, I was really biased against the hardware solution. But actually, more recently, there are studies which show you can promote synaptic health. Now, you can promote new synapses being developed. So although you can't retrieve a neuron, you can generate new synapses. So on that basis, maybe there is something to it, but we don't know yet.
Okay.
Two-part question then. Firstly, does singing in a male voice choir count as the musical instrument that you were talking about earlier? And secondly, do contact sports cause dementia?
Well, the first is that this hasn't been established yet. So there's a lot of people propagating that music instruments and the fact that you do such a complex task will give you a lot of reserves. And that is just, you're just making a road network that is so dense, and you have so many options that if one connection fails, you can get there through the other route. That would help, and it makes sense, and if you start early it does make sense, but it's not beyond proven. But there's a lot of people who are very passionate about it, as they are about their hobby. So I don't know, I don't think people know have tested whether singing is equivalent to playing the harp or a violin or a piano, right? But most people think, okay, that is a higher cognitive function that will not be easy, and therefore it's like education, whether you do this calculation or this approach. So that would be my short and long answer to that. We just don't know.
There's also the social stimulation, isn't there, from
Yeah.
being in a male voice choir, compared to just performing. There's that too, isn't there?
But that's, it should be late then.
Then the effect of contact sports. So I think the strongest evidence probably is in American football, and there's quite a lot of evidence in terms of the trauma caused by the head injuries in that sport. Football, especially if you used a leather ball, there seems to be some emerging evidence for that, but I'm not sure the data are really. You guys, you may know that better than I do.
Briefly, I had a discussion with the PFA over this about a month ago, and my reading of the evidence is the safest position to play on the football pitch from a dementia point of view is the goalie. And I thought that was really strong evidence, actually. Now, the challenge, of course, is what do you do about it? And it is interesting that in kiddies football, parks football, heading is banned, I think, under the age of 12. And as I have a grandson, I am delighted.
You're teaching him how to goalkeep. And also more recently the issue about rugby, and that isn't also worked out.
Can I fire off a quick question? Cornelia, I think the issue with epidemiology is that we're very good at seeing links between risk factors and an outcome. So we see that people with obesity, they run a high risk of dementia, for example, people who have uncontrolled hypertension. Now, the thing that is sometimes it's a bit more troublesome is to prove that if you actually change the risk factor, that you reduce the risk. So, and from that point of view, is there a sort of a, what do we know about this? Which of these risk factors, if you eliminate them, if you lose weight, does your for example risk factor reduce to the risk factor of somebody who's always been thin? And what do we know about this?
That's a very important point. Some issues are difficult to test because you can't give somebody a head trauma and hit him and the other one not. I think it's not ethical, right? So that is not doable. But what we do know, I think that also Masoud mentioned, and I totally agree with, the evidence that strongest is for blood pressure. That there really is a clear case to be made that if you have untreated blood pressure, that is the worst thing to think of. Now, there was an issue in my slide that there's a lot of these risk factors are intertwined. So if you are obese, you have a higher risk of blood pressure, and if you are obese, you get a higher risk of diabetes. So the diabetes issue is really intriguing to me because there are people who really are certain that this is a kind of, we always talk about type 1 diabetes if you are a child diabetic, type 2 diabetes if you're late, we call it differently now, but some people say type 3 diabetes is dementia and diabetes. And it's more the field of Ivan himself, but I think there is an issue there, and we don't understand it. We don't understand why the diabetes is so important, and whether we should reduce it. I think there's all reason in the world to do so, because I think it's of a complex that will give you cardiovascular disease that will go to the brain and do bad things there. But how we can usually do that nowadays is that we use a trick that we think, if we can't do a trial, can we do it more smart? So if we know the genes that cause diabetes, and diabetes should cause dementia, then these genes that cause diabetes should also cause dementia. The association should be smaller, not so strong, but if we think about it, diabetes is also quite a genetic disease. So these genes should have the same effect. It is strange, but we can't find that. We can't prove that. And one of the the culprit is apolipoprotein E, because the 4 allele that causes Alzheimer reduces your risk in diabetes. So there's something weird that we don't understand. But that is the way we want to go about it. So we want to prove it in this way, how the genes shouldn't lie to us, I think.
That's fine. Good. Yeah, Simon.
Is there any scope for us for the general public being research assistants as well as subjects of research?
Ooh.
Yes.
Wow. Interesting point.
Wow. So
Citizen science.
Depends what you mean by research assistants. I think we would love to explore that. We would love to engage with you in the co-design and the organisation of studies. There's no question about that. The institutions called universities, they are very reluctant for insurance reasons to formalise this at scale. But if you wanted to give time to helping us, then we'd love to hear from you, and that would force me to go to my head of department and argue the case for change. So there we are.
But on a practical level as well, research nowadays is done very much through this patient and public involvement. You're expected to have consulted, the people that you're creating this wonderful intervention at the time point when you're designing the study. So certainly within Great Minds, we have a panel, like a standing panel of people who have put their hands up to say, if you have a new research through the door, we'd be happy to hear about it in half an hour and give you our opinion. So if you want to take part in that, by all means, drop us a line on the Great Minds email, and we'll include you in the list, and we'll give you first dibs the next time we have a study that's been approached, that we've been approached by. Yeah, good. I did want to ask something else. Because Masood, you spoke about the various different pathologies that are giving rise to dementia. One thing that is all the rage in dementia research at the moment is this TDP43 pathology, which, to be fair, 5 years ago I knew nothing about. Is it time that we speak in a forum about this, about what that means and how that's different from Alzheimer's disease?
This protein has been implicated in very late onset Alzheimer's disease, but is also involved in different types of dementia, like frontotemporal dementia, and also in motor neuron disease, ALS, as well. So there are several proteins that keep coming up in different types of neurodegenerative diseases, and the question is, are they some kind of byproduct of the neurodegenerative process, a secondary phenomenon, or are they a primary phenomenon? In some instances, they appear to be primary because there are genetic causes which lead to TDP43 being produced. But in the context of Alzheimer's disease, I think it's really something in the very older people that's been identified in the 90s and 95-year-olds, and they don't seem to have the traditional, conventional Alzheimer pathology, but develop dementia at a very late stage. So I think we don't know enough about it, actually.
Yeah, good. Another question from the floor.
Hello, Simon Hunt, Oxford. First, a comment about citizen science. I imagine there must be all kinds of data sets that are just too exhausting and labour-intensive to be able to analyse properly. And I know for sure that astrophysicists have managed to distribute their data sets to citizens all around the world, and those people are turning up with all sorts of interesting things, which the scientists themselves just don't have the person power to be able to analyse. So I'm just wondering whether there's anything equivalent in the area we're talking about.
Yours, Cornelia.
Oh dear. Well, there's a couple of problems that we are encountering. So I think if you look at the secrets of success, how we have these developments in the past 10 years, then a lot comes from genetics. And in genetics, we were so not amused anymore about having results that we couldn't replicate, that we started to work in consortia and starting to add up the data together and do the maths. So that didn't mean we pulled the data, because that often had either scientific restrictions, people don't like that, but on the other end, you also see that that also working with somebody else's data is not that easy. And I think John gave good example that there's so many things to know usually about these data sets that are peculiar, that you have to take account of, that you should think about that. But there are definitely multiple examples, like UK Biobank, that is available to all. That was now, it was a national study that set up more than 20 years, around 20 years ago, and that is available. But the big advantage of these newer large studies is the consent was given that the data could be shared. And many studies that are older, for instance, the Rotterdam study and the Framingham study, you don't have that consent. And that makes it very difficult to do. But I think what John does, I think, is actually overcoming this, right?
Yeah. So we run Dementia's Platform UK, another part of it runs what's called its data portal. And we bring together data from about 3.5 million individuals that any scientist can access, any scientist around the globe can access. Now, the reason we don't send it out like the astrophysics community is that these data are very sensitive because they're personally identifiable. In one sense, to know this is Alpha Centauri doesn't much matter. To know it is John Gallagher makes a big difference. So rather than have the data sent out so that we don't really know, we can't control what's happening, we have a big sort of like a data lake, and we invite the scientists to come in and analyze that. And over the last few years, we've had over 1,000 requests, from several hundred countries, 100 countries, several hundred institutions, and it's just beginning to take off. So that's the way we approach it. It's the other side of it is that the data are normally not very usable, so we invest a lot of time in cleaning the data and make it accessible, so that the scientists, individual scientists, don't have to do that.
And then just two quick ones about study design. 8,000 people might sound like quite a lot to the layperson, but actually in statistical terms, it's pretty small, isn't it? For the kinds of complexities of things you're trying to analyze and find associations for, you need 100 times that number, don't you?
Yes. But I think because this is a really important point, there is a difference between selecting people to test a very precise question, which is what we use great minds for, and collecting data at scale to test a very broad question. So although there are lots of nuances between those two extremes, I completely agree with you. Our data portal does the 3.5 million, and Great Minds does the several thousand.
Thank you. And then just the final one. Is there any plan to look analytically at what you might call the ultimate, at the autopsies of because my dad was a consultant pathologist, and he said that is the definitive answer, and it isn't until you do the autopsy you don't actually really know what, at least histologically, went on.
So Oxford actually does have a brain bank, and from people who've been involved in the Optima study.
Yeah.
So they were followed up. I don't know if you were part of that, Simon, but they've been followed up for many years, and they also donated their brains. So it's possible to link the pathology, as you say, which is really the gold standard in terms of what actually working out what was underlying their cognitive impairment, and tracking it back through what happened in time, over 20 years. So we do have that. It hasn't been completely mined to the extent that you'd like it to be, because one thing is there aren't actually that many pathologists, brain pathologists, in the country. We have to import them from Germany. That's where they're trained. Or Scandinavia. Yeah.
Seriously, you will have a rich data set on function,
Yeah.
which did not exist when the Optima brains were collected.
Mm.
And so you'll have the follow-through. And are you not asking the question? Aren't we prepared
No,
to
we
give
are-
our brains when the time comes?
I think it's a very important question, but what you have to realize that by the time you come into autopsy, you have a completely degenerated brain. So that gives you also a limitation to know what is at the start of the disease. And as Masoud discussed, what has been the breakthrough for most people in the search for medication is that we moved to a situation that we said if the patient is still alive, we can look at the PET scans for amyloid and tau now, we can see it. And if we also see the neurodegeneration, usually at the MRI or where cognitive function, then we think it's Alzheimer. But if you would look at the end-state brain, well, you don't see a lot of the proteins that cause the disease. The strangest thing of all...
AI is coming into pathology and they're picking up all kinds of things.
Yeah.
We're going to see that.
But it assumes that there is a piece of brain still good. And the nasty thing about Alzheimer's disease, it starts spreading. So it starts in the hippocampus, the temporal lobes, and then somehow it starts spreading. And that is the problem, that most of the brain is affected. It's what you usually see, it's completely shrunken away by the time we get to it, and particularly the parts that where the start is. And that is so difficult, I think.
Yeah.
And that is the thing that you always fight with the pathology.
Yeah. So I completely agree with both of you, actually. And very occasionally, DPUK makes investments in other studies to enhance them. And we made an investment to repeat image 10,000 people from UK Biobank. And from that, UK Biobank leveraged an awful lot of money to repeat image 60,000 people. So you have 60,000 people, complete genetics, baseline imaging, repeat imaging, and then they will get repeat imaging. And just 2 weeks ago, we put together a protocol for requesting brain donation from these people. Now, there's a way to go, all right? You know, these things are not done lightly. You know, there's a way to go, but nevertheless, it's in motion, and I expect it to be the richest source of well-characterized sort of lead-in data brain tissue anywhere in the world.
Okay. Well, I'm aware that we've hit 4:40, which is the declared end of the event. What I'm going to invite you is that if you have more questions, just catch one of the panel members as they mill about. And in the meantime, this recording will be available on the Great Minds website. So if you wanted to go over anything, by all means, we'll have all the slides and the actual presentations online. And yeah, as I said, if you are not part of Great Minds and you do want to become, then on the table there's essentially a printout of the steps you'd take in order to join us. Okay, with that, I'd like to thank everybody who made it in person, as well as everybody who was online. And until next time, which is going to be in about 6 months, and we're taking suggestions as well for next topics. So in your feedback forms, by all means, let us know what the next topic around dementia and brain health you'd like to see covered. Thank you very much.